This morning, Ismail El-Hamamsy is here. Ismail is trained at the Montreal Heart Institute. He spent 4 years in London in the Imperial College getting his PhD with Magda Yakub, and it's been specifically sort of laser focused on the aorta and the aortic valve for his whole journey. He's one of the busiest North American root surgeons in practice right now and has a specific interest in the Ross procedure. So he's going to talk to us today about the Ross and about rethinking the guidelines. I didn't warn him that I'm not the biggest Ross fan, but I'm going to keep an open mind today. So Ismail, come on out.
Thank you. Well, good morning, everyone, and thank you for the invitation and the opportunity to be here today and address you about the Ross procedure. Obviously, the Ross is an operation that's being performed here on a regular basis with Dr. Stelzer, whom I had the opportunity to learn the Ross procedure from a number of years ago now. This is 10 years ago, the Ross Summit in Atlanta, which was run yearly, and I learned from many mentors. This is Donald Ross here, Professor Yakub there, Paul Stelzer here, and then I'm the imposter in the back there But I'll tell you what, in the last 10 years, I mean, thanks to all these pioneers and their generous teaching, I think the Ross has really is making a very solid comeback. So I don't really have any significant disclosures, but I definitely do have a bias. And my bias is based on the title of my PhD thesis, which you see here, which is the living aortic valve. And my presentation is mainly 3 points. The first of which is to try to convince you that the aortic valve and the aortic root is far more than just a passive structure that opens and shuts in response to changes in transvalvular pressure. The aortic valve is a very complex, very sophisticated, but certainly very living structure that is in continuous contact with its hemodynamic environment. This is a study from the Stanford group looking at sheep hearts, living sheep, where they put radio-opaque microsonometric beads in all the different component parts of the aortic root, in the annulus, the sinus of Valsalva, the sinotubular junction, the leaflets. And what they looked at is the geometric deformations of the different component parts of the aortic root during the cardiac cycle. What's most interesting in this study is not only the fact that there are torsion movements and elongation and enlargement, but importantly, these changes in geometry of the aortic root components precedes the changes in transvalvular pressure, both in systole and in diastole. And what that tells us is that, again, the aortic root is a living structure. This is what allows a big bolus of blood to exit the heart within a very short systolic period of time without any gradient through a normal tricuspid aortic valve. And the reason is when you look at a cross-section of an aortic valve leaflet, an aortic valve leaflet looks very much like a blood vessel. It has a monolayer of endothelial cells on both the aortic and the ventricular side. It has a population of cells within the body of the leaflet called interstitial cells, which have contractile properties with smooth muscle cells. They have secretory properties with the fibroblasts and the myofibroblasts. The extracellular matrix is very tightly conserved with collagen on the aortic side and elastin on the ventricular side to allow these leaflets to bear the diastolic load. Importantly, aortic valve leaflets are only about 1/3 of a millimeter in thickness. They open and shut over 100,000 times every single day. It could not be that this is a purely passive structure that opens and shuts. It is constantly repairing, remodeling, and adapting to its environment. In fact, if we look even closer at aortic valve leaflet structure or microstructure, you see these neurofilaments in the body of the aortic valves. And their function remains very elusive, but again, their presence testifies to the complexity and the sophistication of aortic valve leaflets. They're far more than passive structures. And in the lab, this is just one of many studies that have been performed and published in literature. We looked at the mechanical properties of aortic valve leaflets and the regulation of these properties in response to various endothelium-dependent agents. And what was particularly interesting is the fact that in terms of stiffness, the elastic modulus of aortic valve leaflets differs in one axis from the other axis. But importantly, the stiffness of aortic valve leaflets adapts depending on what we added to the organ chamber or the organ bath. When we added, for example, endothelin, the leaflets became much, much stiffer. And that can mimic a situation of hypertension or systemic hypertension in the body, where leaflets would then become much stiffer to bear that higher diastolic load. So again, these aortic valve leaflets are far more than than just these little open-shut trapdoors. And there's a whole body of literature around that, which I won't belabor, obviously, but just to, again, to say that this living structure translates into complex function, which for us clinicians translate into a perfect laminar flow through a normal aortic valve, absolutely perfect hemodynamics through a normal valve, very low thrombogenicity because of that layer of endothelial cells which produce nitric oxide and therefore prevent platelet aggregation, as well as resistance to infections because they can mount an inflammatory reaction. And when we look at our patients who undergo aortic valve replacement or even mitral valve replacement, clinically relevant outcomes such as survival, valve-related complications, and even quality of life are all determined by these properties of whatever we put in there. The type of flow there is, whether there are any gradients, the hemodynamics, is there mismatch, the thrombogenicity of the valve, do the patients require anticoagulation, and obviously the risk of endocarditis in that valve. So the rationale behind any valve, any operation that aims at either preserving a living aortic valve in the aortic position, so a valve sparing or a valve repair operation, or having a living aortic valve substitute, is that would translate into improvements in clinically relevant outcomes. Now let's remember that the focus of this presentation is non-elderly adults. They're not the 70 and 80-year-olds for whom we perform most of aortic valve surgery nowadays, but these are patients mostly under the age of 60. And what characterizes these patients versus the majority of the elderly patients is their high level of physical activity. Quality of life is obviously important to all patients, but it's particularly important in these patients who are professionally and physically very active. But the most important difference is their prolonged anticipated life expectancy, which translates into a longer exposure to potential valve-related complications, whether that be degeneration and reoperation with tissue valves or bleeding and thromboembolism with mechanical valves. So my second point is that conventional aortic valve replacement in these non-elderly adults is associated with excess long-term mortality. And I'll show you some of that data. But before I do so, let's just remember that conventional AVR has several advantages, whether it's mechanical valve or tissue valves. These have been used for many, many years. They're very standardized operations. They're easily reproducible. They come with very short operative times. And we have long-term data to support their use, especially in the elderly patient population. But if we look at that specific non-elderly patient population, the data is rather more sobering than it is for their older counterparts. This is a study from Sweden where they have a population-wide registry of all patients undergoing cardiac surgery, where they looked at observed versus expected survival in patients undergoing aortic valve replacement, whether with a mechanical or a tissue valve. And what you see is, I don't have a pointer. What you see is after about 7 or 8 years, the observed mortality in the black dots is significantly higher than the expected mortality in the white squares, as you can see in that graph. Again, these are all patients undergoing aortic valve replacement. One may argue that perhaps this is mainly driven by the older patients having a higher mortality than would be expected. But in fact, when they stratified the patients according to their age at the time of surgery, perhaps counterintuitively, the younger patients had a much higher OE ratio than the older patients. Patients under the age of 50 had a 4.5 OE ratio after aortic valve replacement, as opposed to patients over the age of 70, which had exactly the same observed survival as the expected.
Remember, I know we have a tendency to interrupt because this is just.
Yeah, absolutely. Please go ahead.
We're trying to understand things, and you're going pretty quick. And I'm not elderly, but Paul's elderly, so I'm going to over 70. I want to make sure my elder colleague here on the front row has time to process this. But I think we have to be a little careful of this interpretation of your data because these younger patients may have a different disease than your older patients. Makes your ODE a little more interesting, right? I mean, unless those were all aortic stenosis patients.
True, and I'll get to that point in the next slide because that's.
I'm just calling everybody else.
Yeah.
Thinks we're watching a revolution. Paying attention because we have to separate out AI and AS when we're trying to understand survival curves after AVR.
True.
Or AVR.
O2E, what does that mean?
It means that the observed survival is exactly equivalent to the expected survival. There's no difference between two.
What does that mean? What does it mean for 70 years old? That means matched to the population?
Yeah.
Compared to the age and gender matched general population, yeah.
So if it's a 70 years old guy who has aortic valve disease and he dies and he had surgery, his expected mortality or survival is similar to the matched population?
After aortic valve replacement, yes. That's what that data shows.
Well, it's in this paper. It's in this paper. As you
And-
know, there have been many papers that suggest the ODE is less than 1 because you only operate on healthy people. The sickest 10% of people, or 5, especially in the pre-TAVR era, didn't get AVR. So AVR, like at Cleveland Clinic, appeared protective, but really this was selection bias toward who you operate.
Yeah, that's obviously a component. And also the expected survival of patients or individuals over the age of 70 or 75 becomes matched to these patients. But what this data shows, or suggests at least, non-definitively, is that younger patients have a higher excess mortality in the long term after aortic valve replacement with prosthetic valve. Now, to go back to your point, so when I went back to practice in Montreal, what I thought was to lay the picture of what we're really doing in our practice, at least, for young patients whom we defined as patients under the age of 65, undergoing isolated elective aortic valve, mechanical aortic valve replacement. And we excluded anything that we thought may impact long-term survival. So patients who had concomitant procedures, coronary disease, emergent operations, dissections, endocarditis, reoperations, really took everything out. These were patients with bicuspid aortic valve stenosis who underwent isolated elective mechanical AVR. The mean age of the patients was 53, and they were followed for a mean of 9 years. So pretty significant duration of follow-up. And again, looking at their survival at 10 years and 15 years after surgery compared to the age and gender matched Quebec population, you can see that there's a significant difference already at 10 years between these patients and the general population. And that gap continued to widen as the years went by. In fact, when we combined reoperation, although it's a rare event after mechanical aortic valve replacement, but still an event, with mortality, survival free from reoperation at 10 years was a mere 82% in these patients. So in other words, at 10 years, 1 in 5 patients were either dead or reoperated. And this was mainly driven by death rather than reoperation. So again, it's a signal that there is something, or at least there's room for improvement, and perhaps things are not as rosy as we thought it was, and we're certainly not curing these patients by replacing the valve. Now, there are newer valves that seem to be to work better and require less anticoagulation targets, and that has been shown to translate into fewer bleeding events with no increase in thromboembolic events. And this is the ORAC trial, which you well know. Except when you look at the actual data from this trial, and these were patients that were very closely monitored with home anticoagulation monitoring. In the low INR group, the 1.5 to 2 group, look at the linearized rate of major events, major bleeding, all thromboembolic events, and thrombosis. It was a 4.5% patient year, which is a very significant rate of events. If you add that up over time, that's almost half the patients at 10 years which will have a major event. Of course, I don't think this translates linearly up to 10 years like this. The follow-up in this trial was 3 years, but nonetheless, at 3 years, it means that 15% of these patients had a major event. Now, what about tissue valves?
These patients also had a surprisingly high structural and valve degeneration. I mean, I was shocked by how many reoperations were happening in that trial. I don't have the number in front of me, but I remember when I discussed this paper once, and I was surprised also that I think the lower anticoagulation did translate into more issues with valve performance. But anyway, sorry, keep going.
No. The trend now is to implant more and more tissue valves in younger and younger patients with the promise of valve-in-valve technology down the line. This is a study from the Cleveland Clinic looking at survival after AVR for AS in over 3,000 patients from 91 to 2004. And their conclusions were very similar. Younger patients had a worse than expected survival that was further diminished by insertion of a small prosthesis. So introducing the notion and the importance of patient prosthesis mismatch in these young patients who are physically active, which I think is particularly relevant. This is another study looking at tissue aortic valve replacement in young adults from France of over 2,500 patients. And again, when they matched survival of these patients in the long term compared to the age and gender matched French population, look at how when they stratified the patients according to their age at the time of surgery. What you see in black is the survival, the observed survival of these patients, and what you see in gray is the expected survival in the age and gender matched population. Again, there's a significant gap between observed and expected survival, which diminishes as the patients get older at the time of surgery. So the same thing that we saw with mechanical aortic valve replacement. In fact, they went further and looked at that very specific patient population of 50 to 65, in whom we are increasingly considering putting these tissue valves in order to put a valve in the future. And what they showed was actually very good durability of these valves, with a median durability of 19 years, freedom from structural valve degeneration in a patient between 50 and 65. That's a pretty good proposition. If you take a 55-year-old and you can bridge him all the way up to the 70s and then put a valve in there, that sounds like a good proposition, except when we look at survival of these patients, almost half the patients were already dead 15 years down the line. And of course, if you're dead, you will not have structural valve degeneration and you will not require reoperation. So we always have to be wary of simply looking at structural valve degeneration, because these are competing risks. And survival free from reoperation in this trial is actually not so convincingly good. And we, again, performed the same study that we did with mechanical AVR, with tissue AVR in our patient population, again, excluding anything that we thought may impact long-term survival, mean age of around 50 and mean follow-up of 10 years. And again, survival of these patients was significantly lower than the age and gender matched general population.
I had to, just because I don't want to forget, you're looking at AVR and mechanical valve in your own institution over time, which is the analysis Joe Wu tried to do respectively in the state database in California. And there are things that lead you to do you did many more mechanical valves than bioprosthesis.
Correct.
I don't know what the number was, but it was substantially more. So your bias was to use mechanical valves
Correct.
during that time period. So you have to be very convincing to me anyway that there's not a selection bias in higher risk patients, or patients that you don't trust to come back to them in a clinic, or patients that you have some suspicion about survival for getting by.
Absolutely, no doubt about that. And I think patients with chronic renal failure, or patients with heavy diabetes, or all these patients you put on tissue valves because you think maybe they're.
Show us the data.
But
This is the flaw.
This is the flaw of that paper. But still, I think it's 10,000 patients undergoing isolated AVR under the age of 65 in a pretty contemporary period of time. I think there are many limitations to this paper, including the duration. The mean follow-up of this paper is not long enough to provide 15-year data, which they provide in the graph. But nonetheless, when they stratified again the patients according to age, this is the 45 to 54-year-old patient. This is the 55 to 64-year-old patient. And the 15-year mortality in both groups was 26 to 30% in that group, and 32 to 36% in that group. So in other words, 1 in 3 or 1 in 4 patients, only 15 years down the line, was already dead after isolated AVR. Granted, they include all sorts of patients. These were not, carefully distilled patients, excluding anything that may have a significant impact on the long-term survival. But 10,000 patients is a lot of patients, and it just gives an idea, or a signal at least.
That's bad to have an AVR when you're young. This paper suggested that within 30 days, patients that got bioprosthetic valves had higher mortality, but said the populations were the same. Obviously, that intuitively shows you that there's a selection bias toward bioprosthetics in higher risk patients that they're not explaining. But I agree with you.
Cumulatively, yeah.
Having an AVR when you're young is not great for blowing out your 85th birthday.
Exactly, and so the bottom line from all these, these selected papers, obviously, and there are many more, is that I would submit to you that conventional aortic valve replacement in non-elderly adults is far from being a curative procedure. It is at best a palliative procedure, and that's why we need to try to address that in ways that perhaps may improve outcomes. And that excess mortality is not just observed in patients aged 20 and 30 at the time of surgery, but really up to the age of 60 at the time of surgery. So the question is, does a living aortic valve in that position improve outcomes or not? I know it sounds like a far-fetched question, living and clinically relevant outcomes, but just if you bear with me, I'll show you why the Ross procedure seems to translate into improvements in some of these outcomes. Now, going back in history, the Ross procedure was first described in 1967. This is the seminal paper by Donald Ross in the Lancet. Interestingly enough, 2 years prior, Norman Shumway had published this paper, and this was an animal study looking at replacement of the aortic valve with the autologous pulmonic valve. So perhaps Donald Ross was, the idea was floating across the ocean at the time. It is the only replacement operation that guarantees long-term viability of the aortic valve and root. We have explants up to 30 and 40 years after the Ross, showing that trilaminar structure with endothelial cells, interstitial cells, and that extracellular matrix within the body of the leaflets. Now, you're well aware of the general sentiment, when it comes to the Ross procedure, that it transforms a single valve disease into double valve disease, high operative morbidity and mortality, high rates of reoperations, which sometimes may be prohibitively high. And I think some of these concerns are founded and are true, but I'll show you why they may be a little bit exaggerated and perhaps they need to be toned down a little bit. What I will focus on today is just survival, because survival is really a binary outcome. You're either alive or dead. You can't be half or half. And so I think it gives a pretty good idea of what happens to these patients. And we have enough long-term data now to give us an insight into how these patients fare. When I was in London with Professor Yacoub, I was lucky enough to analyze one of the few prospective randomized trials in valvular surgery, where in the 90s he had randomized patients to undergo either a Ross procedure or homograft aortic root replacement for aortic valve disease. These were patients aged 39 at the time of surgery, and they were all-comer patients. 8% of these patients were operated for active endocarditis, and almost half these patients were redo operations, with the most common previous operation being a homograft aortic root replacement. So you will agree with me that these patients were not destined to a great future after surgery. And nonetheless, when we looked at their long-term, or at least survival up to 13 years, you look at the Ross cohort and the UK age and gender matched general population, the survival was exactly identical between these two groups. The group in the homograft root replacement had a slightly lower survival than that observed in the Ross group. That got different groups to think and analyze their data, and I'll show you some of these results. This is Tyrone David's series from Toronto, 212 patients aged 34 with a mean follow-up of 10 years. And look at 15-year survival in these patients, exactly identical to the Ontario age and gender matched general population. Of course, there's patient selection in all of these trials that I'll show you. This comes with it. But despite the patient selection, I still think that there's a signal that needs to be studied. They updated their series in Toronto a few years later with now a median follow-up of 14 years, a pretty significant duration of follow-up. And again, survival remains equivalent to the general population. And looking at survival free from reoperations, about 75% at 20 years in patients aged 35 at the time of surgery, which is a very challenging patient population. And this was mainly driven by reoperation rather than death, as opposed to the other way around, as I showed you in the prosthetic aortic valve replacement series. Well, you may say this is Yacoub on the one hand, this is Tyrone on the other hand. They're single surgeon series. The Germans put all their Rosses into a German Ross registry. So a number of surgeons, 8 centers, over 1,700 patients, aged 45 at the time of surgery. And again, a mean follow-up of 8 years, but a third of these patients were followed for over 10 years. And again, survival at 15 years was exactly identical to the German age and gender matched general population. And this was their conclusion. This is the Brussels series, 300 patients, 42 years of age, a median follow-up into the second decade. And again, survival at 15 years was similar, although there was a drop-off in survival at 20 years in that series. In the UK, they have a national registry of all patients undergoing cardiac surgery. So they propensity matched these patients between those undergoing a Ross, a mechanical, or a tissue aortic valve replacement. And again, survival free from reoperation seemed to be better in the Ross group versus the prosthetic aortic valve replacement group. Again, propensity matched analysis does not account for all the differences and all the variables known or unknown between patients, but still pretty good survival free from reoperation in that patient population. The Toronto group looked at their Ross series and they performed another propensity matched analysis of Ross versus mechanical AVR and looking up to 20 years at their outcomes. The freedom from cardiac and valve-related mortality was significantly better, again, in the Ross group versus the mechanical AVR group. And the most recent of these papers was published in JACC just a few months ago. Peter Skillington series in Australia, 400 patients, again, using propensity matched analysis, long-term follow-up of patients aged 43, and at 20 years, the survival of the Ross cohort was significantly better than that of the mechanical AVR cohort. And there are many more studies in literature that I show you here in that table, busy table, which I'm not going to go specifically through, but just to tell you that looking at 15-year survival, everywhere you see a double asterisk is survival that's exactly identical to that of the age and gender matched general population. And the most recent meta-analysis was just presented at the ESC meeting recently, comparing Ross versus mechanical AVR, and again showing lower all-cause mortality in the Ross cohort. So I'd submit to you that despite patient selection, or with patient selection, I think it is the only replacement operation to this day that seems to restore long-term survival in carefully selected patients following aortic valve replacement. Now, what is the Achilles heel of the Ross procedure? I think it's twofold. One is the risk of reoperation, and secondly, perhaps it's the operative risk as well. And indeed, if you look at reoperation rates, there are studies showing alarmingly high rates of reoperation within 10 years after surgery. This is the Rotterdam group, and at 10 years, only almost 30% of these patients had required reoperation, most frequently because of autograft root dilatation in the aortic position. Now, you look at these data and you may think, well, let's just throw the baby in the bathwater together, forget about the whole thing, and just drop the operation. Except they actually looked at these patients who came back for reoperation because of autograft dilatation. And what they did show was that most of that diameter increase was already reached at hospital discharge. And I think dilatation begets dilatation in these patients. But what this really says is that technique really matters when it comes to the Ross, not just in terms of safety of the operation, but really in terms of the durability of the operation. And the technical tips and tricks and the ways to really improve that durability have been learned over the years. They've been taught by surgeons performing these operations for many years, such as Dr. Stelzer. And they're much better understood now and much better defined what these success factors are. But we have to go back to the basics and understand differences between the aortic and the pulmonary root. The aortic valve and the aortic annulus is a fibrous structure, at least along the aortic mitral continuity. And that provides structural support to the aortic valve. The pulmonary valve does not sit within the fibrous skeleton of the heart. It's pushed upwards by the infundibular muscle. And once we harvest the pulmonary root, this muscle here becomes devascularized, it becomes necrotic, and it provides no structural support to this pulmonary valve. So the first thing to understand is that the pulmonary valve needs to sit within the aortic LVOT, so that the native aortic annulus provides support to that pulmonary valve. So the proximal suture line needs to be implanted very low. And the muscle below the insertion of these leaflets needs to be trimmed. Instead of leaving a long sleeve of muscle to quickly sew it, we need to leave at the most about 2-3 millimeters and scallop that muscle, as you can see here in this little video. In terms of implantation of the pulmonary autograft, as you can see, you need to push it in a way that it sits below the aortic annulus, so that this then becomes the actual support to the pulmonary root. And to do so, the stitches have to be passed, and they have to come out very low in the LVOT. You'll see here that the stitch comes out much lower than it would if you're simply doing a regular aortic valve replacement. And then I use interrupted stitches, and I go right at the insertion of that leaflet, and I try to run the needle tangentially so that it comes out at a level just a little bit above the insertion of that leaflet, so that when you parachute the pulmonary root down, it is really parachuted down within the LVOT with the native aortic annulus providing support. The distal suture line is also really important, and I think for a long time, especially in patients that had a dilated aorta, surgeons would keep a long sleeve of that P8 artery instead of trimming it and replacing the aorta. And that PA is not used to systemic pressures. It can easily dilate, stretch the sinotubular junction, and induce AI. So it really has to be trimmed very short. Once the autograft is in place, we put these 3 stay sutures right above the commissures, the 3 commissures, and then using a curved scissors, I just cut the entire pulmonary artery right above these commissures, leaving absolutely no residual distal pulmonary arteries. So that the only pulmonary tissue there is left is really just the sinus of Valsalva tissue. And this is the final look once we remove that entire pulmonary. You see how the left main artery reimplanted is right next to where we're removing that pulmonary artery there, and it really leaves no residual distal pulmonary artery. Importantly, in patients that have a dilated aortic annulus or present with aortic regurgitation, these are the patients who we know have the highest risk of reoperation and dilatation long term. And there are many ways that one can address this dilatation to try to mitigate that risk in the long term. Our favorite approach is to use an extra-aortic ring annuloplasty and replacement of the ascending aorta right at the sinotubular junction. So I do this systematically for all patients who present with AI or mixed AS-AI with predominance AI, or any patient that has a mismatch in the diameters of the annulus between the pulmonary and the aortic. And this is the final look once you do so. You've got your ring sitting on the outside of the LVOT. So it's the exact same suture line that you would do when doing a reimplantation procedure, except instead of having a full tube, you only have that ring sitting on the outside to stabilize the aortic annulus. And we've showed in various papers that this proves very stable over time. And this is what it looks like. We dissect all the way around the aortic root, just like when doing a valve sparing procedure. And then these stitches are passed in the horizontal plane along the basal ring of the heart. I use 6 stitches there. And once these stitches are passed, the pulmonary autograft is then harvested. I measure the diameter of the pulmonary annulus. And based on that diameter measurement, we pick the size of the Dacron ring that will be used. The Dacron ring needs to be about 5-6 millimeters larger than the diameter of the pulmonary annulus to account for the thickness of aortic tissue on both sides. So once these stitches are passed, this is the Dacron tube that we'll use to cut the ring. The ring is about 4 to 5 folds high. Once that is done, the stitches are passed through that ring. So again, it's exactly like you're doing a reimplantation procedure. Once you've passed those stitches, the ring is then lowered down around the aortic root, around the basal ring of the heart, and then they're tied over a Hagar dilator, which is sized just like the pulmonary annulus diameter. And this is the final look from the inside. This was a 32 millimeter diameter, which now measures 26 millimeters. And we're presenting a paper at EACTS just next month looking at patients with AI versus AS who underwent the Ross procedure, showing very stable annular dimensions, sinus of Valsalva dimensions, and freedom from AI or reintervention, up to 5 years only, so very short duration of follow-up. But like I told you earlier, I think that early dilatation begets late dilatation and predicts late dilatation and reoperation. So I think early stability of these diameters is particularly important and perhaps may mitigate some of that reoperation. We won't eliminate reoperation, but if we can lower it, it would be a significant win. And finally, the most, I think, important and sometimes overlooked element is blood pressure control, not just during hospitalization, but after discharge. And we aim for a maximum systolic pressure of 110 in these patients for the first 6 to 12 months after surgery. And we use remote monitoring system where patients get measured their blood pressure at home. They upload their measurements through an app on their iPhones, which immediately feeds our systems. And I'll just show you an example of a patient that left the hospital with perfect blood pressure control, but just within a week after resumption of activities, the blood pressure shot up to about 130, 140. That is immediately transmitted to us, so we adjusted his medication more than once, and after a few weeks, we got him exactly where we wanted him. And over half the patients who leave the hospital with adequate blood pressure control, we need to adjust their medication at least once or twice after discharge. Now, using all these things and all these lessons learned, we can look at the freedom from reoperation in some of these series in literature. This is the randomized trial with freedom from reop of 94% in the Ross group at 13 years. This is Tyrone's propensity matched analysis between Ross and mechanical valves, where actually they found no significant difference at 20 years in terms of reoperation rates between mechanical and Ross procedure. This is the German Ross registry showing a 1% patient year reoperation rate, so about 10% at 10 years and 15% at 15 years. And again, all these other studies that I mentioned earlier which include a fair number of patients with pure AI at the time of surgery. So really the highest risk patients to undergo reoperation and dilatation. And despite that, the linearized rate of reoperation in all these studies was about 1% patient year again. So I think with attention to technical detail, the risk of reoperation can be maintained in the 1% patient year range. And finally, the last question is it riskier than standard aortic valve replacement? I'll just show you our results from the Montreal cohort, because I think it's representative of it includes a learning curve, it includes a surgeon's learning curve. So these are our volumes since we started our program in 2011. And you can see the volumes have been gradually increasing from year to year. And that is part of a broader program of aortic root surgery with valve sparing and aortic valve repair operations and the Ross procedure. And we started off from a center where we had no real volumes or expertise, quote unquote, in aortic root surgery. So really this includes, as a center, our learning curve, as a teamwork around these patients, our learning curve. I think what I'm proudest of so far is really having 98% completeness of annual clinical and echo follow-up, and these are the team of people working with me to ensure that all these patients are followed very adequately. But importantly, these patients were aged 42, and again, they were slightly all comers. 15% of them were redos, 5% had active endocarditis, and a little over half had concomitant procedures, most frequently ascending aortic replacement, but some of them had other concomitant procedures. And our overall operative mortality was 0.6%. So again, very comparable to patients undergoing a regular aortic valve replacement. And there definitely was a learning curve. In the first 100 patients, we had significantly more complications, more temporary dialysis, more re-exploration for bleeding, and our 2 mortalities. But you can see that once this operation is performed regularly enough, it becomes a very safe operation. And thankfully, no mortalities in the last a little while. So having seen all this, what is the current usage of the Ross procedure? Well, as you well know, there's almost no usage of the Ross procedure, by and large, except in very select centers. This is the STS database showing very low usage, and especially an important decline in its usage in the last 15 years or so. And there are many reasons for that. It's technically, obviously, a more complex operation than regular AVR. And we know that low volumes translate into more complications. And these are young patients, so their stakes are obviously higher when performing these operations. I think we're now there's a general culture of risk aversion in cardiac surgery, which makes it difficult to start programs or to start more complex procedures in young patients when we know that the operative risk may be higher. The general sentiment has not gone. And I think that, when we look at some of this data, we can easily dismiss that data as being, not exactly right. This is an editorial by Tyrone saying that he thinks the best operation to treat aortic stenosis in young and middle-aged adults, but we can, again, deem it to be unreal news. And if we look at the practice guidelines are supposed to align evidence with the recommendations. But if we look at the ACC/AHA guidelines, the most recent iteration, the Ross is a Class 2B indication, and it mentions that replacement of the aortic valve by a pulmonary autograft, when performed by an experienced surgeon, may be considered in young patients when anticoagulation is contraindicated or undesirable. So only when it's contraindicated or undesirable. And it's a Class 2B indication. Except when you look at the references that are used to support this recommendation, none of the papers, none of the studies that I showed you, including a prospective randomized trial, systematic reviews and meta-analysis, nothing was mentioned. These are all papers that really only barely address the Ross procedure. So these are really expert opinions, consensus guidelines, but they are what they are. The European guidelines in 2017 don't even mention the word Ross procedure. It simply does not exist in the range of options for patients, and these are for young patients. It's a mechanical valve or it's a bioprosthesis, even in young female patients contemplating pregnancy. There's not even a mention of the Ross procedure. So I think when it comes to the practice guidelines, there's a real misalignment between evidence and recommendations when it comes to the Ross. I think if you believe the evidence, there's a real paradigm change from the simple question of anticoagulation versus reoperation in a young patient undergoing aortic valve surgery to really looking at survival and quality of life. We have enough data now that we should be asking these questions when consenting or informing patients at the time of surgery to be able to better inform our decisions and, importantly, their decisions as well. In Canada, we've had a bit of a ROS renaissance over the last few years with a number of centers starting ROS programs in London, Ontario, in Toronto, in Hamilton, in Sherbrooke, and in Vancouver just next month. Well, I'll be helping them start their program. And all these patients are entered into a Canadian ROS registry. We now have actually just over 500 patients that are all prospectively followed annually with echo and clinical follow-up into a unified database. And recently we put out a position statement where we mentioned that for young patients, we recommend that the ROS should be considered as an alternative to prosthetic valve replacement in young adults with bicuspid and tricuspid aortic valve stenosis and or dilatation. And we made this a strong recommendation with medium quality evidence. So I think this is more, to me, a reflection of what is out there in the literature as objectively as possible. And I think the trend is towards re-examining some of these guidelines. These are some of the editorial comments that have been published in recent years, or in the last couple of years, really. This is from Tyrone's. This is from the Josta Pedersen in Cleveland. Is it time to reconsider use of the ROS procedure for adults? This is Mike Borger in this month's issue of the JCVS. The ROS procedure, time to reevaluate the guidelines. So I think there's a general move towards at least reevaluating the role of the ROS in today's armamentarium. So in summary, I think that in young adults, the choice of prosthesis has a direct impact on long-term prognosis, including survival and quality of life. And conventional AVR is associated with excess long-term mortality versus the general population, including in patients undergoing isolated and elective aortic valve replacement. And I'd submit to you that the ROS procedure with a similar operative risk is able, of course, in selected patients, not in all patients, to restore late survival, excellent quality of life, certainly better hemodynamics and freedom from valve-related complications, which I did not address in this presentation, but there's a whole lot of data to support some of these outcomes in these patients. So again, I'm very grateful to Paul for teaching me over the years about the ROS we run. I'm very happy that we run this course on a yearly basis, and in 10 days we'll be running it for the 5th year now, and we have about 50 surgeons registered coming up to for a 2-day course with live cases and wet labs. So again, thank you for your attention. Thank you for the invitation to be here, and I really look forward to our discussions.
Ismail, that was great. I'm going to ask you just a couple of more things and turn it over to the floor. But one thing I wrote down was the 1% per year reoperation rate in very good centers. Is that what you tell patients today? If I come to 1% per year.
Yeah.
So how and I think part of the problem we have with the evidence is the comparisons are all made to mechanical prosthesis, which I told you last night. I would never get one, and I don't think I've put more than 1 or 2 of them in the last 5 years. So I've jumped to that conclusion as well. I don't want one, and I don't want my patients to get one because I believe the data. You do change people's lives forever, including their life expectancy, which I think is what you're showing us. And the same was true in the mitral position. The same was true in the New York State database when we looked. If you have a mechanical prosthesis, and we agree well, we saw one trial that was very carefully monitored, 5% per year risk for bleeding.
Yeah.
And what we showed in a publication in JAMA in New York State is if you got admitted to the hospital with a mechanical prosthesis for bleeding, you had an 11% mortality. Patients think it's all I cut myself with my garden hoe. I have to go get a couple of stitches. It was a 1 in 10 chance of dying if you got admitted with bleeding on the valve. So it's a big deal, which is why we have such a bias against it. But 1% per year for the first decade is exactly what we tell bioprosthetic patients. Right? I mean, you would say that to me if I needed a bioprosthetic valve, I hope.
But I wouldn't say it to a 40 or 45-year-old patient coming for a bioprosthetic aortic valve replacement. I think at 10 years, the risk of reoperation is at least the risk of significant valve degeneration. Reoperation is a bit of a, and it applies to the Ross as well. Maybe we sit on them forever, and don't reoperate. But I think
You have that luxury because you fail with AI.
you fail with AI, which is a bit more, yeah. But I do think that the rate of reoperation and failure of a bioprosthetic valve in a 40 or 45-year-old patient is significantly higher than 1% patient year, even within the first decade. I think it's a good 2% patient year.
We'd have to go back and look at that together because I think for your first 5 or 6 years, you're pretty much home free with the bioprosthetic valve. You're not home free with the Ross.
No. But the other thing I would say,
I think they're going to be pretty close at 10 years. Now it's going to change at 15 years.
Yeah.
I think they're going to be pretty close at 10.
So that's one element. And the other element I think that's important is, let's remember that about 20-25% of our patients leave the hospital with a certain degree of patient prosthesis mismatch. Now, I think in patients age 75 or 80, that may not be as significant. But in young patients who are physically active, whose cardiac output is not what it is on the echo table, and whose gradient on the echo table is in the double digits already, when they're moving and they're running up and down the stairs or they're jogging in the park, that gradient is systematically over 20 millimeters of mercury or so. And it keeps getting worse as the valve degenerates. So if 25% start with a bit of mismatch, maybe 10% have reoperations at 10 years, but these LVs may not be as happy during these years.
I hear that argument all the time, but I must say that the medical literature doesn't suggest that unless you have a velocity 4.5 per second high in your output tract, it doesn't impact survival at all for native aortic stenosis.
Yeah.
I know there's another cult out there about patient prosthesis mismatch, but how do you explain the discrepancy between 20 millimeter mercury gradient across your aortic valve can increase your mortality by 5% at 5 years, but we follow asymptomatic AS with gradients double that for 2 decades, saying that when you look at age-matched patients, they live the same.
Yeah.
You see what I mean? It is a fallacy.
Yeah.
Native aortic stenosis should have the same impact on survival, and it's never been shown in any medical observational trial.
It has not. We're currently doing a
I'd rather have a lower gradient.
Yeah, no, I agree. I see what you mean. Yeah. And we're trying to argue with evidence. So you're right. There is no solid evidence to support. So
the other one I wanted to ask you about was the sinus of El-Salve measurements between AI and AS. I noticed those were different.
They're different by 1 to 2 millimeters, but in terms of statistical changes, it wasn't statistically different. And from a clinical standpoint, it was 2 millimeters, just because with the bar on the left was, but it was 2 millimeter difference, and both of them were under 40, so it was still within sort of normal range.
Yeah, I mean, I think that what your data shows again is master surgery by master surgeons. And patients do extremely well. And I think, I'll ask you a question about what you think the reason the Ross procedure fell off the map. What was the reason for that?
Well, I think.
Remember the Trojan horse paper? That was a clever title. That showed a lot of the world. But what do you think it was? Other than that paper, what do you think it was? Just a bias against some of the early failures without support at the angular level?
I think there was a lot of that. I think it was a lot of low volume centers and surgeons performing an operation which requires, very intricate understanding of the anatomy and its impact on durability. That was one element. So that's in terms of durability, but also in terms of safety. There's no doubt it's a longer, more complex operation than a simple aortic valve replacement. And the STS database shows it. It was a triple the mortality rate with the Ross than with a simple AVR in the STS database. But all the centers performed about 2 Rosses per year. So I think that, and you've shown and published about that extensively, anything that is a little bit more complex that is performed at low volume, inevitably it will just give it a bad name.
I think it takes, there's a the number for mitral valve repair for degenerates right now is starting to get pretty good. It's starting to grab at 25. That number has been shown in different work, including a paper we published a couple of years ago in JACC. It's been readopted now by Leapfrog at 23. Virginia suggested 25, or the analysis done in the Virginia health system. So there's a lot of Frank, the appreciation that 25 seems to be a pretty good number. If you do 25, if you're as a patient, if you select a surgeon that does 25 degenerative valve repairs a year or greater, it appears that your reoperation risk and 1 year survival improves. I think that number is getting some traction.
Yeah.
How many Rosses do you have to do a year to join the club? I noticed your first 5 papers were receivers, or first 4 were receivers, Elker, Kevin, David, Matthew Gatker. That's pretty good start. How long does it take to join the club in terms of Ross procedures per year?
Per year? Well,
Get good at it.
yeah, to get good at it, I think there are 2 elements to the answer. One is it needs to fit within a broader aortic root surgery program. So you need to do it with aortic valve sparing operations and aortic root replacements, standard Bentall procedures. I think if you have a volume of about 30 to 40 of these cases overall per year, that gets you very comfortable with managing the root, symmetry, mobilizing coronaries, doing all these things. Within that, I think it has to be probably around 15 to 20 Rosses a year, I would say, to be very comfortable and proficient at it.
How many surgeons in the United States do 50 a year?
Not very many. How many would you say, Paul? Maybe
There must be data.
less than 10?
Yes.
Yeah.
Certainly less than 10.
I mean, these are the hurdles that we face in every reconstructive field, which is that it's fun. They're fun operations, but unfortunately, it's not part of a lot of practice.
Yeah. But I think the lesson learned is that they need to be concentrated in centers where there's a dedicated, not just single surgeon, but really expertise and cardiology and a team. And doing that, I think we can have very standard results and expect good outcomes in the long term.
Paul?
Thank you so much for coming, Ismail, and sharing this great talk with us. It's interesting to look at the way you built this program. So, in a sense, those first 5 years were like four valve sparing operations.
Yeah.
They kind of got people convinced you knew what you were doing around the aortic root, and then all of a sudden it just started to flower and just shot up like crazy when you got part of it is you looked over the alternatives and saw that was not a bed of roses.
Yeah.
And that's an important perspective. That we tell people, mechanical valve, you'll never need another operation, and Coumadin's not a problem. And those are 2 big lies. It's not a problem, but you'll not need another operation if you're dead. That's true. You showed that. But those competing risks here, so that we have to think about. And even if you have a 3% mortality for a Ross operation, as opposed to a 1% or less to do a mechanical or a tissue valve, you look out at 15 years, you're still ahead to have had a Ross.
Yeah.
That's a psychological barrier that people have to get over. And you have these Tula papers and others and I think there was a lot of kind of thought leaders and centers like Mayo and Cleveland anti-Ross for quite a while, and to see editorials coming out from Cleveland and saying maybe we should be offering this more to young people. On this series of papers that have been published in the last year that all support a survival advantage for the Ross, that we better figure out how to do this. And then when we saw the Trojan horse paper, that a lot of people, I think that was a seminal point for a lot of people who were trying to learn how to do it. We're having trouble doing it. Here's a good excuse for me. I don't have to learn how to do this. It's not a good operation. We'll quit doing the operation. And that's one response to that data. The other is we need to do it differently. Why is it failing, and can we affect that? And that's what you showed. You can't leave a dilated aorta. You can't leave a dilated aorta. And even kind of my last thing, I keep trying to improve it. And when I see those different survival curves, I've said, well, if I only pick the ideal patient, the AS patient with normal room size, no ascending aneurysm, I can put you on that top curve all the time. But sorry, you have AI, you have a dilated aneurysm, you have an aneurysm. I'm not going to. Which one of these other curves should I put you on? How can I put you on this one? Can I do the operation differently? Can I support it like you're showing? Take care of the aorta. don't let the anchors die. And I even claim for native aortic elements or even extra patches around the sinuses, so you don't see that part. But some people have gone to the full jacket, the Davidized Ross. We put a vascular graft around it, put it in there, then sew that in. And that's worked pretty well in some people's hands. It's a little bit trickier to pick the right size graft.
Yeah.
And, you know, when you introduce new things, you introduce new problems. But addressing those problems and continuing to try to pursue the survival advantage of having a living aortic valve, I think is worth doing.
Yeah.
And you've shown that that can be done. Even starting from scratch, like you did in Montreal. You've done a great job.
But Paul, we could never, the only thing I disagree with, you could never support ever a 1% perioperative mortality rate versus 3% for an AVR. You could, that argument would fall. I certainly go for that because what you've got to, that is the 10, all the stuff you're showing me is all retrospective stuff. And again, now I've learned today, if you get a Ross in Montreal, you get very tight blood pressure control by your Apple phone while you're under follow-up. So I'm learning that there are, as I say, there are many differences when you study a population. That's why robotic micros go home earlier when you're in the publishing phase, because you're pushed out the door no matter what. That length to stay down. But I was going to say that now I've learned again, your Ross patients have better. I bet your blood perivalve patients don't get the same blood pressure.
They don't.
Yeah.
No doubt about it. Yeah. And when these guys get a cold, they call me, and they're immediately seen by a pneumologist. I think that feeds into the difference. These patients are followed closer.
Which I do believe is that if you could do it with the same operative risk, then the discussion gets much more interesting. But you can take increased risk in elective patients for the hypothetical 15 years later based on these gobbledygook of data and all these patients. Because remember, we all have to look at survival curves, but we all know cancer patients that were told they had 2 years that lived for 10. And so there's we all have to live and die by evidence based on populations, but for the individual patient, I'll take my chances. I'll take 2% less operative risk and bet on medicine a decade later. I think you have to start with, you can do the operation with the same degree of safety, but that will only happen by volume continued expertise. It couldn't happen on one in a million because I went to a Ross course in Montreal, and now I'm going to try 2 Rosses. Those patients are undergoing a significantly more risky operation than let's say by that surgeon. It's not done before, so it has to be introduced and fostered very carefully.
There's not just a few patients either. Like we heard that talk in Cleveland about minimally invasive aortic valve. There's only 2 deaths for 350, but it's kind of waiting for 400. It really is 0.5%. So what do I tell the patient that I've been doing Ross on? Well, I now have over 450 Rosses in a row without a death, without a take-back for bleeding. Is my rate 0?
I love that too. We have to keep the streaks intact. We're on quite a good streak.
That's something that I don't think I can't say anybody else around can do that, but it says I can compete with the
That's a pretty good winning streak.
And that rethinking the Ross paper that says the 3% mortality rate in the STS database, if you look at that data carefully, it wasn't an average of 2 per year. About 60% of the losses that were actually analyzed were done by centers that did less than 5 in 14 years.
In total, yeah.
14 years, less than 5.
Yeah.
And the mortality was only 3%. It's a miracle. A lot more.
You're taking healthy people the hour that should have no mortality. That's the whole point. Okay, we got to go where we're Maddie.
I think the number to treat and the number to harm is more important than absolute reduction. So if you see it, you have to, if you reduce it 2%, it means you have to do the 50 more operation. You should go every single operation perfect. So I think the absolute reduction doesn't make sense. So you're going to tell the patient, but you have to see how many operations I'm going to do perfectly to get that result.
Okay, president and then
I'm going
person.
to make a few comments if you don't mind, because I know this topic quite well. Although I don't do the operation. When Kuchuk was published his studies in 1994, everybody got excited about RAS procedure, and including multiple surgeons. At that time, I was in France and started doing that. But year 2000, everybody stopped doing that. And one of the reasons you don't see them in the European guidelines because there's a lot of negative data out there that they haven't been published. And now you look at a country like Spain, nobody does RAS operation in Spain. Portugal, nobody does RAS operation. So it's very difficult for European guidelines to come up with an operation that are not done in entire countries. So that's one issue. The second issue is that the outcomes that you mentioned, you should, study it with 10,000, AVR. Unfortunately, with RAS operation, we are still with the same group. It's Tyron Davis, it's El Khoury, it's, we don't have 10,000. And your study was from Bourguignon, he was my resident, from a small town in west of France, when they did 2,500 AVR. We want to see some outcomes with, a RAS operation, maybe in Arizona with not 2,500, but at least a few hundred. We don't see that. It's a very good operation with very expert people. Otherwise, it won't work. And if you show the data from German registry, there are at least 5 centers with 3% mortality, and a few of them above 5% mortality. And you are telling me 2% versus 1% is acceptable. I mean, in 45 years, like at Sinai is 0.2%, it's not even 1%. And at 3%, you qualify for TAVR, you don't qualify for AVR, even at 80 years old. So it's a very high mortality. Again, you don't have it because you have developed an expertise, but unfortunately, it cannot become standard of care because only a handful number of people are doing that. And that's, I think, one of the weaknesses of this operation, which has evolved over time, and now it looks like getting standardized stabilization of the annulus or the distal anastomosis. But the real interest in RAS operation is not becoming because of the good outcomes of the RAS operation. It's becoming because the field of elderly, as mentioned, AVR is disappearing, so there is a more focus in younger patients. And now we are saying the AVRs are not doing well in younger, whereas before we have a huge denominator. Younger were 10%, elderly were 90%, so most of the focus was in 90%. Now this 90% is disappearing, it's going all to TAVR, so we're stuck with 10%, and we're looking more carefully, and we're saying, maybe in 10%, we should do something better than an AVR.
Yeah, I couldn't agree more with your first point in that any of these complex operations, if done have to be done in expert centers, and we're certainly not, the message or the take-home message should not be that everybody should be doing ROSs. I don't think everybody should be doing ROSs, just like I don't think everybody should be doing complex mitral repairs or valve-sparing reconstructions. So that I agree with you about. I think the resurgence of interest with the ROS precedes the advent of TAVR and the fact that we're trying to shift the attention to somewhere where, as surgeons, we still have a say in the game. Because all these studies really came at a much earlier stage than I think it was just a timely coincidence that now, with TAVR being on the forefront for these elderly patients, it makes it even more of a perhaps a reason to delve and to investigate and to understand and to these more better fitted operations for younger patients. But I agree with you. I think any of these operations, and I think a valve reconstructive surgery, when it comes to the aortic root, valve sparing operation in a valve that leaks, and a bicuspid valve with a bit of this and a bit of retraction, to me is a lot more complex even than doing the ROS procedure. ROS is no more than a glorified Bentall at the end of the day. But a reconstructive aortic valve root surgery is much more involved of an operation. So there's no reason why it could not be taught and made reproducible in the hands of surgeons with high volumes and in centers where there is a team around the aortic pathology.
It's interesting, I'm just looking at this very large paper that was published from Switzerland last year, and I'll tell you, which makes the same argument I did in a debate with Hartz and Shaft a while back. This is, I can't say these names in France, it's such an awful language. Bourguignon, who's that for? It's B-O-U.
This is Bourguignon from Tours. Yeah, that's the guy.
I love the French. Okay, Okay, so I'm reading his paper. I think you showed one of his slides.
Yeah.
I'm reading his paper. I noticed you conveniently left out things that didn't fit your message, which is what I do too, so I recognize it very well. However, I'm reading the comments. The main finding of the study is you didn't see that from the data he showed you. The main study of this study is that the incidence of valve-related complications, and particularly the incidence of structural valve degeneration, was much lower than expected according to available literature. Indeed, the expected valve durability, this is of the Magna East valve, pericardial valve. Expected valve durability calculated by the median survival time from the actuarial freedom from SVD was 17.6 years.
Mhm.
Reoperation for SVD was a common outcome, but this was also associated with a very low mortality, and the mortality of the 82 patients that underwent a second operation mean at 17. What do you guys think? Take a stab.
1%.
This was in France, by the way. That's not the Cleveland Clinic.
So less than 2%.
Less than 2%. So again, as I tell the patient, now your first operation, my gosh, in our center was 3 years in a row with no mortality. So it's not zero mortality, but it's darn low. And 15 years later, I subtract 2 years just because it feels good. 15 years later, your second operation should be done with a less than 1 or 2% risk. So that means over your next 30 years, and by the way, the second operation will have a much lower rate of a much lower chance, be better than 15-year chance. So if you're in the right heart center, stage bioprosthetic valves is an excellent choice, particularly if you don't have a skilled Ross surgeon. If you have a skilled Ross surgeon, then the argument gets to be much more interesting and academic, because you're right, then you're going to have a better valve performance, I think. But that's why the guidelines are written that way, because in the general population, you don't have a great Ross surgeon, and you get 2 bioprosthetic valve operations, you should be able to, you should have a probably 2 or 3% cumulative operative mortality, and that should get you 25 or 30 years cumulatively over a 2 or 3% risk. And that's what I asked Hartzell when we were debating this about, because he says mechanical prosthesis, and I said, so if I get a bioprosthetic valve and I come back to you 12 years later and I need a reoperation, I've never been in a hospital except for the 5 days I was in the hospital for the AVR. What's my risk of reoperation? Low. How low? Really low. And so that's the counter argument.
Yeah.
That I think your data is convincing me that if you could get a Ross and say you're 45 or 50, it looks like a really good operation. Like that 38-year-old that wants a mechanical valve you were telling me about last night. I wish he would get a Ross now, but I've revisited this data. When's the cutoff? Like, what's the age cutoff for you? When does it become? Because remember something, which I tell people all the time in the robotic space. You can take Jordan Spieth. He won 2 majors. I love golf. He won 2 majors in a row, and literally in back-to-back Masters and the U.S. Open. That's so impossibly hard to do. Super skilled golfer.
Yeah.
But my life depends, and he's obviously gone through every learning curve. He's a top 10 player in the world. That's Seaver, the same guys you said, Seaver, Curry, David, Yakub, El-Hamamsy. Oh, you can have your Ross by Stelzer. There's the 6 guys that will do your Ross. But if I ask all of you guys to do, just like I asked Jordan Spieth, my life depends on it. I'd much rather have a little short pitch shot that most amateurs will get right 60% of the time than to hit a shot only 2 or that an amateur is going to get right 1 in 10 times. If he's got to clear a lake and hit it 300 yards in a high soft shot with a 4-iron that he's going to fade a little bit to make it stop before it goes behind the green in a creek, I'd rather him just hit a little 80-yard pitch shot that anybody on the front row that's played golf once every week is likely to hit in the middle of the green. Because if I give him the same shot, he's more likely, his target with the harder shot is a quadrant of the green. His target with the easy shot is 6 feet below the hole.
Yeah.
Breaking right to left. So like his, his ability to execute his easier shot, just like your ability to execute the easy. You wouldn't be up there bragging about 272s. Not bragging is the wrong word. You wouldn't be up there presenting as a relevant data point for a master aortic surgeon 282 Magna valves in a row going home. I mean, it's good. That's like I made 100 4-footers. That doesn't get you on. That doesn't make much noise in the tour. Now you make 30 10-footers in a row, they start talking about you in Golf Magazine the next week as the hottest putter on the tour. So you're hitting hard shots and getting perfect results, which is why it's relevant. If it was easy shots, no one would care.
Yeah. I mean, I would answer with
understand what I mean?
absolutely, but I think the same argument would apply for, let's say, aortic valve sparing surgery. So I think valve sparing surgery is, assuming that Ross is hitting that shot across this and that, valve sparing surgery is much the same level of complexity, requires the same understanding of the aortic root, the anatomy, the complex interactions out there. Yet, I think the general sentiment, we wouldn't think of valve sparing surgery much the same way that we approach the Ross. Valve sparing surgery we see as a safe operation, as a very reproducible operation somehow, and where any center that offers it, we say, well, that's fair game. But I don't think it is. I think much the same way the Ross can be made not into that very complicated golf shot, perhaps not the little chip shot, but certainly something that's reproducible, so that not only the Spieths and the McIlroys of this world can do it, but the top 50 players can do it, let's say.
I mean, I'm curious for a few more comments. I actually, having sat here and listened to all this, I actually think that the patient, or the average patient, really isn't getting a balanced, informed consent in most places. In other words, they're just pushed into these mechanical valves when they're 45, almost just, and the guidelines actually help that.
Yeah.
As opposed to a more active, sort of philosophical discussion about the 3 different options. And you may, by the way, have to go somewhere else if you want a Ross operation.
Yeah.
Down the hall in our program, a Ross operation, but here are the issues. And I think, that kind of informed consent is our obligation to patients. Do you agree?
Absolutely. But I think it has to be data-driven as much as possible, with all the flaws and limitations of data and patient selection and reporting biases, and people do not report poor outcomes.
Data, though, is you've got the wrong randomized trial. I mean,
Yeah.
you really need
Yeah.
a randomized trial between bioprosthetic valves and
Yeah.
Ross procedures in patients less than 60. And by the way, I would accept the 5, 6, 7 centers we just said running that trial.
Yeah.
And showing us the data at 4 or 5 years, because if you could establish the safety of the Ross in master centers versus bioprosthetic valves at the same time, then you'd be halfway home. I think everyone would agree they'd rather have, all things being equal, I'd rather have a bioprosthetic valve at 6 years if I was alive and I had normal valve function.
Mm.
But you haven't proven that, because the homograph is not as good as the
No.
bioprosthetic valve.
Yeah.
Your control group is worse than a magna valve.
The homograph was used as a substitute for the best available tissue valve at the time, and
Yeah.
they were at least as good as any existing tissue valve for an aortic homograph. That's what my view told me.
Yeah.
Rationale, and I think made sense. But nowadays, we think a little differently about the
homographs.
consideration of tissue valve.
Yeah. I mean, this was early 90s when he started the trial. So it was, homographs were still en vogue and from a hemodynamic standpoint, he thought it would provide the patient with the best hemodynamics. So he thought.
We're all, because I was a resident with the ICahn for 6 months, as you might be aware of, and I helped Dr. Ross do a Ross procedure during a live course, and I then took care of the 34-year-old patient that was on a balloon pump for a couple of days with an anterior wall that wasn't working too well. And I thought to myself, man, that looked really hard to me. I was just a little trained, a young surgeon at the time, but maybe I was a little over-biased by watching Dr. Ross do something that I thought he would be again, that'd be a pretty good pick for a surgeon to do your operation. And it wasn't a question whether he's a great surgeon. It was a question was he was doing an operation that's much harder than a standard bioprosthetic valve operation, prosthetic valve operation. But anyway, who else has a comment? I went.
Great presentation. So just one thing, we have done a lot of mechanical AVRs for patients with rheumatic heart disease, and you see the morbidity and mortality of these young patients coming from both that they get pregnant, etc. And I remember when I saw the first loss in my life in Germany, which was also a surgeon who would do maybe 3 or 4 cases max a year. Again, giving a hint of the limitation of the Ross procedure. But I thought that would be a perfect for the rheumatic disease because they are young patients, they don't have aortic, some isolated aortic valve problem, and it gives them treatment from pre-interventions for many years. Also, considering the cost and the availability of the pulmonary grafts in developing countries, which can be an issue. But if there's anything also, why this surgery was not basically not adopted in areas of the world where you have non-compliant patient and patient, you need a patient free.
Yeah, no, I mean, this is a great point. And the largest rheumatic series with Ross is from Zuhair al-Halis in Saudi Arabia, almost 500 patients. And they show good results, not nearly as good as with patients with bicuspid AS or congenital aortic valve disease, particularly in patients who have active rheumatic disease or patients who are not put on prophylactic penicillin long term. So these are, I think, the two conditions. If you catch them in the chronic phase rather than the active phase and make sure that they take their prophylaxis, then you can expect good results. I think the main limitation is perhaps a technical limitation and, more importantly, a homograft availability issue. Homografts are not easy to come by. In fact, in Europe right now, they have a real issue with Ross. It's just because their homograft banks have really gone dry. It used to be, hospital-based. Every hospital had in their basement some tissue bank. Now they can't do that anymore, and they don't have the centralized bank. So human tissue is very hard to come by. Now, one of the ways to overcome that is to use a freestyle on the right side. And some centers in France have been using them quite regularly. And they've published data up to 5 years showing good durability, but we don't have any longer follow-ups with that.
And how the redo would be for that?
Well, for the right side, the approach now of choice is really to go percutaneously. And I think if you have a freestyle on the right side, it shouldn't be that hard actually to go implant either a sapien or a valve in there or a melody, but you may as well put a sapien in there. So I think in that sense, it actually lends itself quite well.
I have a question, Dr. Lamson asked this question. What is the absolute age cutoff for Ross?
Yeah, I mean, there's no absolute, but I think the way I look at it, if the patient is active and has an anticipated life expectancy of 15 years or more, whatever that means, that sort of puts the cutoff at around 60 years of age, where we have the conversation with the patient. It sounds very aggressive, but like I say, I think if we can propose the operation with a similar operative risk, with the purported benefits in the long term, a patient that is closer to 60, I expect this to be, in all likelihood, his last operation. I mean, he has a much higher chance of this being his last operation than coming back for a redo. So that's how we sort of approach this.
How do you counter the argument that which also Dr. Lam started with? You have a 55-year-old in your office who is asking if I get a prosthetic valve with a root enlargement, which most surgeons are offering these days, what the chance of the TAVR 10, 15 years down the line or 20 years down the line? Why do I need to go through a Ross procedure?
Yeah.
And if I can get a redo, like Dr. Lam said, at the center, that's a 2% risk.
Yeah.
Less than 2% risk. Why do I need to go through a Ross procedure?
Yeah. Again, based on the data that we have, and it's all with all the bias and all the limitations, I think there are survival, valve-related complications, hemodynamics are three important elements to favor, or at least to argue for considering the Ross procedure in these patients. The hemodynamics are certainly better from the outset and 10 and 15 years down the line. So I think the LV, although unproven to translate into real clinical sort of events, is happier, for lack of a better word. The risk of endocarditis and all these other things is lower. We now know the issue with subclinical thrombosis of these valves, and we're being more aware of it. That's not an issue with the Ross. And whether we choose to believe or not these survival curves, I think the older or the closer you are to the 60-year cutoff, maybe the less relevant it becomes. But these are some of the arguments. But the older the patient is, the less sort of aggressive we are at sort of at talking the Ross. But
I love this guy. I love surgeons because we'll get to I'll get to another point in a second. I just would listen to you. But how come you're less aggressive?
No, I shouldn't say less aggressive, but I would say, yeah, I said it. Because I think I'm less convinced that the benefit is as obvious at 15 years.
But again, the other part you're leaving out, which I'm going to help you say, is that you're less convinced of the benefit, and you deep down in here somewhere in the far recesses of your brain with Dr. El Curry and Dr. David and Dr. Stelzer, even though you've done 400 in a row, there's just this teeny little increase because it's harder. Like if you wouldn't care about the benefit if you thought the risk was the same. You'd keep doing it for the next patient you were going to do a Ross on. So there's a tiny little.
Yeah, I think the tiny little.
We all have it.
No, I know, and the tiny little thing is not as much for that, but then for the reoperation, for the say 10% who may come back for reop when they're 75.
You're taking a little more.
Yeah, that will. Well, it's harder, it's riskier, and at 75 doing redo after a Ross is not the same thing as a. And you can't offer him a TAVI. So for all these reasons, that's what.
I would challenge you is that what you guys have to do is make the argument more clear. Meaning, it's not just around 60. You could be 65. Your hobby and love of life is riding your competitive bike in the mountains in California, which we see once a year in the mitral world. So, and then we also stand you and your aortic root. You're not getting better 21 unless we do.
Yeah.
It does increase your risk 2 or 3%.
Yeah.
You're a perfect candidate.
Absolutely.
For loss. Whereas you're 56, you're going to get a 25 bioprosthetic valve. There's not a shred of data that a 25 bioprosthetic valve versus Ross at 57 or 58 can impact your survival one way or the other. I'm going to do the easier operation for you. Or you're Layla, and we're hoping we can get a 19 in you. We're actually geez, look who lost the lottery. We get to operate on Layla. I hope we can get any kind of valve in her without doing some crazy thing. She's like a perfect candidate for a Ross. So I think part of the problem is you've got to reintroduce the operation in a more aggressive way, but we also have to be more selective, respecting the fact it is more surgery. And like you said, it's more surgery down the road, which I haven't heard before, but you're being very honest about it. It is a hard operation. Reoperation later down.
Yeah.
Oh, we got so many things. It was Gilbert and then Annette and then we'll stop. Gilbert first.
Yeah, so 2 questions. One is, when patient come into your clinic, when we say you're not a candidate for Ross, I mean, that's some of the things that at least the resident and others know. Second question, have you ever had to you go in there, you open the chest, look at the valve, say this is not a Ross, and then you convert? Because I think some of the things we're on top of is what's the conversion rate?
Yeah. So these are good points. The absolute contraindications of patients with connective tissue disorders, so anybody with the Marfan, Lewis Dietz, or the patients with a family history of dissection, I would strongly not consider doing a Ross. And patients with autoimmune disorders are also at a high risk of reoperation because of autograft failure. So patients with Reiter syndrome, with lupus, with rheumatoid arthritis. The conversion rate is not zero. In my series, I'm not sure about yours, Paul, but my series of these, I have had to convert in 3 patients, and the 2 of them were. One of them was because of a bicuspid pulmonary valve in a patient who was in his 50s, who had a large aortic annulus, so I thought I could put a big bioprosthetic valve in. Not to say that a bicuspid pulmonary valve is an absolute contraindication. I have used them twice. One in a young 20-year-old patient who had a very small annulus. She wanted to have kids and the whole thing. And the valve looked very pristine with 180-degree commissures. We used that. We're now 5 years down the road and it's still working perfectly nicely. And another patient who was a redo actually had a 19 mechanical AVR performed in Mexico, actually moved to Canada, and she was very symptomatic. Came to put the pulmonary valve as a bicuspid. We still used it, and again, we're a few years down the road. I don't think it will be as durable as a regular tricuspid pulmonary valve, but I certainly think it still provides them with good hemodynamics while it lasts. The other 2 patients that I had to convert were patients with large fenestrations in their pulmonary valves. So you do see fenestrations, and I have used a number of those, but these were very large fenestrations that got me a little bit worried, where you see just a little string holding the leaflet at the commissure. I worry about, when you put them in systemic conditions, even though you control the blood pressure, that commissure will rupture, and then you have severe AI in these patients. So these were the 3 conversions. So the conversion rate is rather low in these patients.
How is your case selection, even in younger patients who have associated concomitant mitral valve disease or borderline coronary artery disease, lower EF, endocarditis?
These are the gray zone. Endocarditis, I only go for patients with leaflet endocarditis or very minimal root destruction. If I have to reconstruct the root and do more involved things, then I don't go for the ROS. Patients with a low EF, I think, actually benefit from a ROS, but you have to, sort of weigh the risk and benefit. I think the better the hemodynamics, the better recovery one can hope for that LV. But if the patient is a very sick patient, or from one patient to the other with a 25 or 30% EF, they're very different. If the patient looks like he can take that operation if they're younger, then I would go for a ROS in these patients, and we've done it. For concomitant procedures, if it's a mitral, then yes, we'll repair that mitral at the same time. Coronary disease, if it's extensive or triple vessel disease, or I don't think that it's worth doing a ROS in that patient, because I don't think that his expected survival is perhaps as good. If it's limited coronary disease, focal lesion in 1 or 2 vessels, that I have done, because I don't think it has a significant impact in the long term on their LV or their sort of vital expectancy. But I mean, these are all gray areas, and these are sort of the patients that we follow, and I will learn over time from my series whether I made good calls or bad calls, and I'm sure in 10 or 15 years I'll readjust my answer to your question.
What is your technical tip or experience using homograft in the pulmonary positions to avoid reintervention?
With little tricks, you mean?
Yeah. What do you do differently?
Yeah. What we've learned is we oversize the homograft, so we use 28 millimeters or more, because there's always a bit of an inflammatory reaction. So you kind of mitigate the hemodynamic impact of that by using a large homograft. And the other thing we do empirically is put them on anti-inflammatories for the first 6 months to try to reduce that inflammatory reaction. Now, when you look at the previous papers from the 90s and so on, there was an early hazard phase of pulmonary homograft stenosis, which at least in our series we've been able to almost eliminate from that. But there will be a constant hazard phase, and we see some patients in whom the gradients increase in the first year to 2 years, and then it sort of levels off and it stays like this. So again, I think to me one of the main limitations is the right side, is the homograft. It's not a perfect solution for the right side. Thankfully the RV is very forgiving, but the homograft is not a perfect solution.
This blood pressure control, what's your success rate and the duration of the control? The last one is how active you can be if your systolic is 110.
So you can be pretty active. You may be a little dizzy when you get up quickly, but the body adjusts to it. So in the first couple of weeks, patients complain of having a bit of orthostatic hypotension, which then disappears. What they actually complain of is once you take them off of these medications, that they feel like they're a bit like, but that also after a couple of weeks it's sort of so they can be pretty active. We keep the control for the first 6 to 12 months, and for the patients who are compliant with using that system of reporting and measuring and doing, we actually have very, very good blood pressure control, and we see it day to day. I mean, we have these graphs for every single patient. The compliance rate is not 100% though. So some patients, you teach them, you show them, and they still won't use. They won't measure. They won't use it. It's built into the system. So time will tell us. In fact, if anything, it serves as a control group, and we'll see how impactful that whole sort of setup is in terms of limiting the dilatation of the autograft.
Okay, Ismail, now it's time to see if you've won your. So now we're going to vote. We're going to do the back row first. Why don't you put the first 2 rows together, then the front row? So you or your family member, your age, by the way. I think, what do you think the mean is back there in these first 2 rows? 40 maybe?
About so.
37, 35, I don't know. 30 and 40. Let's right in there. We'll break we want. You guys have Congenital stenosis. You have, which means you don't have a connective tissue disorder. You got congenital stenosis. After operation, you need reoperation. It's going to be, super simple stuff. You can have Dr. You can have Ismail and Paul together. Tyrone, don't worry to do your operation. We're going to get you two guys together. And you can have that operation, or you can have a prosthetic valve. And your estimated size for your bioprosthesis is 23. Won't be 25, won't be 21. We're confident you're going to get a 23. Edwards, pericardial valve, or you can have a Ross. So how many people are going to have a Ross?
They do it.
How many people are going to have a pericardial valve?
For the long-term and the severe synavials.
Now, how many people in the front? And now I'll ask you the same question for your parents, who are all now 59. So how many people are going to have their parents have a Ross procedure? How many people are going to get a pericardial valve? So I think the tissue valve's going to. I think that's why I said I'm convinced that it's. I don't know how big the population is, but I think it's probably a part. How many operations are there for people less than 50 in the United States for aortic valve disease? You guys know? Or in North America? Anybody know?
How many aortic valve replacements under the age of 50 are being performed?
I don't know.
I don't know.
It's an interesting argument because that's what we need to make the next discussion now in the front row. What do you guys think? Everybody.
The answer to that question in the state of New York is 200 a year. Aortic valves under the age of 55. 200 a year in the state of New York.
100 a year.
That's a question I asked a long time ago.
Is that for mechanical and bioprosthetic valves?
That's anybody isolating the aortic valve. That's just desperate. Everybody's people.
Nice practice for single surgery.
Nice practice for single surgery. Because that's one of the reasons we don't have more people than us. I mean, if you did every one of them in New York that could possibly be eligible, you would have 200 people here.
Yeah.
And how many surgeons are there?
Yeah, but Paul, isolated, there's somewhere to that where you've got to be throwing out.
Yeah.
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 A lot. You're missing the population that already gets those operations. But on the front row, how many people are your brothers? 50. 50. Ross or 5 prosthetic.
Which one are you asking? Huh? Raise your hands for one or the other, yes. So we've ruled out mechanical.
50 years. By the way, is anybody getting a mechanical valve in this room right now? I did one thing right. How many people would get a bioprosthetic valve here on the front row versus a Ross? About bioprosthesis.
50 years. About 50.
You're 50. Bioprosthetics. Ross. Oh, I'm getting a bioprosthetic 10,000% of the time. I trust these guys. I'm pretty sure that I got to go for the simplest operation because I think inherently for the individual patient, I think it's interesting once you get under, when you get younger, it gets to be a much more interesting argument. I think once you get to be 50 or 55, it gets hard to take additional risk perioperatively because it's also. Because the other problem is that 1 or 2% that, let's just say it's 1%. It's a big 10 years. You guys are young in the back, but you don't realize when you're 50 or 55, that's a really big 10 years. You're probably taking care of your families on both sides. Meaning that your value of life at 55 is different than your value of life at 65 versus 75 versus 80. Is, and I'm going to take whatever I think is the absolute safest thing. Isn't that it's a really big decade. Anyway, it was a lot of fun. This was
this is an fun discussion for sure. Thank you.